Good evening, everyone. So we have another week of webinar. This time we speak about SLE, something we have not spoken about before. And but the speaker is a repeat speaker because we invited him. Usually I would invite the speakers that I generally find interesting, able to, give a good webinar. And of course, we have my colleague, a rheumatologist from Sunway Medical Center, Dr. Chia.
Hi.
Yeah.
Hi,
Okay.
Patty.
So Chia, can you just introduce yourself just a little bit and maybe tell some of our audience, how do you get actually into the pathway of being a rheumatologist?
Okay, really. Okay, so I'm CHEAH. CHEAH is my name. So graduated from University of Science Malaysia. I think it's almost, wow, yeah, over 20 years. Um, why I did rheumatology? Why I do rheumatology? Good question. If I were to tell you that my initial intention was nephrology.
Oh, I see. You wanted to do rheumatology more interesting than nephrology, definitely.
Yeah, I mean, of course, because rheumatology is not something that people know what it's all about. When you don't know about it, you find it hard to actually fall in love lah. My initial intention was nephrology, but subsequently, there was a bit of a pulling and pushing factor. And then I must say that I got inspired by my teacher then. So she introduced me to the field of rheumatology. Well, ever since that, I think if I look back, I have no regret, because I think rheumatology is a very holistic, multi-systemic, holistic. As you notice that it is not organ specific. Every organ
Yes.
can be ours. That is the fun. That is a fun part, but that is also a challenging part, because from top to toe, even to your even cardio, for your heart, for the kidney, everything can be ours. So that's a challenging part. So yeah, so I must say that rheumatology is actually advancing very fast, very fast nowadays, because we are actually involved in many more advanced therapeutic agents. Yeah.
Do you get into rheumatology training after your specialist program?
Yes, I did my MRCP. After I passed my MRCP, after my gazettement, so I opted to join in rheumatology subspecialty program. Then it included 1 year of UK training, overseas training. I got the opportunity to be in one of the best lupus center in UK, the Louis Coot Lupus Center under Professor David Cruz. So that was really an eye-opening experience. Yeah.
Where did you train in Malaysia for rheumatology?
I was with Hospital Tunku Jafar Seremban. Yeah, that
Oh, I
was one of the
see.
yeah.
So that any government hospital can train 4 years of rheumatology? 4 years.
No, it's a 3 years program. No, basically you have to be trained under a rheumatology center who has a rheumatologist accredited as a trainer. And out of the few centers, there are some centers who are the big centers. Selayang is definitely one of the big center. Then we have Putrajaya, Seremban, yeah, and even Pulau Pinang. So the other smaller centers, then the trainees can also be there, but they have to move around in order to go to get exposure in a bigger training center.
Oh, okay. Okay, good. Now we know how to become a rheumatologist. We want to know about SLE. Let's go ahead.
Okay, so this is for Dr. Betty's treat in the lounge for all the free cakes and goodies. Oh my.
Every time I buy the doctor's food because they give me webinar for me, okay? I don't earn money. I have to come out with money.
Okay, so let's start our talk tonight with this topic, SLE or systemic lupus erythematosus. So I'm going to start off with 2-3 simple scenarios, but these are actually not the real patients, but it's just to mimic the pictures of the cases that you may see. So you can see the first case, she's a 25 years old Malay lady with no medical problem. So the presentation that she has was on and off fever, joint pain, skin rashes, and she has increased hair loss for 3 months. So she sought treatment from few doctors but not resolved. So on examination, we noted that so there are oral ulcers. Are they painless or are painful? They are actually painless. Okay, so when you ask the patient to open her mouth, then you can show all these so-called buccal mucosa ulcer. And then there is also vasculitic rashes, and also you can see the puffy joints over the PIP joints and MCT joint bilaterally. And remember to ask your patients to remove the tudung, because that's what you get. For all you know that a patient has a very bad alopecia. And you do the simple blood test, patient has features of cytopenia.
Oh,
Okay, so these are the low white count, low HB, low platelet. So another scenario would be a 45 years old Indian man. Okay, so he's an active smoker for 20 pack years. He works as a lorry driver, shortness of breath for 1 month with intermittent fever. Of course, when he saw primary doctors, of course, he was treated as a presumed respiratory tract infections, given courses of antibiotics but never improved. So he was referred to local hospital with chest X-ray done. So these are the X-ray finding. Okay, as you can see, there are evidence of blunting of costophrenic angle suggestive of pleural effusion. So it was diagnosed as pneumonia to rot TB, but then he was treated with antibiotics and empirically started on anti-TB. But guess what? He didn't get better as well. So, and then eventually when they did further testing, so noted that again, patient has cytopenia, platelet low, total white is low, and the ANA turned out to be strongly positive and a very strong double-stranded DNA positivity. Another scenario that you may see, 23 years old college students brought in by family unwell for 3 months, on and off fever and reduced appetite. Then suddenly, eventually he becomes, he turned to his unusual self, very reserved, quiet, and talking to himself at times. So he was seen by a community doctor and he was even referred to psychiatrists, thought to be mental stress because of his studies. And of course, out of desperation, the family member brought to see some traditional healer, went to temple and so on. So went to the hospital for further investigations. Of course, when you look at the patient has these features of hands, rashes of the hands, and the CT scan, the scan actually shows features of these lesions there. And when you do further blood tests, you notice that there is this evidence of again low count, low HB, as well as a strong albuminuria, and then low serum albumin, and the positive ANA and also double-stranded DNA. Okay, so all these cases that I've illustrated actually show these are all lupus or SLE. As you can see, they come from different background. They come from different gender, background, demographic, and their presentation is actually very heterogeneous. That's why SLE or lupus is also known as a great mimicker. Okay, because it's an inflammatory multi-system autoimmune disease of unknown etiology. So what is it all about? It's an antibody, it's an autoimmune disease. So it is because of the autoantibody formation and then the immune complex problem and then causing all the inflammation and end organ damage. As mentioned just now, in all the illustrated cases, they are heterogeneous in presentation and with a different cause and prognosis.
No, I'm very surprised that 2 out of your 3 cases are men.
Yes. Being a rheumatologist, we get to see some funny lupus. So I have a collection of male lupus in my clinic. Yeah.
Okay. But is it not more common in women?
Yeah, of course. It's more common in women. It's 9:1, the ratio, and it's mostly happening among the childbearing age. But I do have a collection of patients who are elderly, above 60 or 70s onset of lupus.
Okay.
Yeah. So when we talk about lupus to our patient, so you know what are the common response that I get from them? So is it feng sap? So because they come and see feng sap form, so they think everything is feng sap. Is the disease curable? Then when I tell them, no, this is a chronic illness, there's no such thing as cure, then they'll show that kind of a dire response. Is the disease inherited? And some of them will become very dramatic. Why me? Okay, so with all the tears and everything that comes with my tissue, I will supply free tissues on that. And And then when the next question is that I don't know why, somehow our patients or populations tend to really love their kidneys. So they will say that, will this disease harm my kidney, or will your treatment harm my kidneys? And then there are also a group of patients whom, after you explain to them, they just couldn't really catch what you are trying to tell them with just first visit. Of course, you need to actually tell them repeatedly, and get all the relatives involved, and then to come and explain from A to Z slowly. Okay. So how common is lupus? As mentioned just now, it's not common, but because it's only like, around the world, there's only around 5 million documented people. But again, like what I mentioned just now, God seems to created this for women. 90% occurs more in women, 10 times more susceptible. There also some contribution on ethnicity. So as compared to Caucasians, the Asians are more common, and then they are more common among the African American women.
Oh, I see. Oh, okay.
Yes. In terms of the severity, they are more actually severe than in Asians and African American women as compared to Caucasian. But survival rate is good in Western countries, but I can't say the same for Asian population, honestly speaking. Okay, when we talk about SLE, it's just one of the autoimmune diseases that we see. Okay, there are many autoimmune diseases that can be divided into organ-specific or multi-systemic. So SLE is a textbook presentation or hallmark of so-called multi-systemic autoimmune disease, whereby it can affect your organ from head to toe. Yeah. How common is SLE? This is the study in the West. Prevalence, as mentioned, most of the SLE is actually detected in a mild form, 50%. But again, this is a Western data. I can't say the same for the Asian, because when we notice the Asian data seems to show that we tend to have a more moderate disease presentation. Why is that so? Probably there's a bit of genetic susceptibility, but again, it also involves the problem of so-called late identifying the patients when in early stage. I mean, as compared to the Western country. Okay, how does SLE happen? Well, nobody knows, but again, we always say that there's a combination of genetic and environmental factor. You are born with a kind of genetic predisposition. There have been few number of genes being detected, as you can see there. We don't have to know in detail, but the genes there doesn't mean that you have SLE. So that is a point that I would like to stress here. If your mother has SLE, doesn't mean that you have SLE. It's just that you have the kind of a genetic predisposition. You must have the kind of a second hit or some trigger in order to actually activate that kind of abnormal or aberrant immune response. Only then it will lead to cycles of inflammation, and depends on which organ is involved, then it will affect all the target organs. Okay, so it's a very heterogeneous disease. It can actually affect your organs from top to toe, as you can see. Luckily, I must say luckily, because the commonest presentation are the ones with so-called milder forms, which is involving the skin. Acute cutaneous lupus, 70%, and then malar rash, oral ulcer, and subsequently the most arthritis as well, Then the more severe components such as neurological or so-called hematological and renals are relatively much lower. But once you get the kind of major organ involvement, then unfortunately your treatment paradigm or treatment armamentarium will definitely switch to a more so-called intense type. Okay, so how do we classify SLE? Okay, many years ago, even before I was a medical student, we used the ACR 1980 plus criteria, whereby you have 4 out of 11 criteria, then you tick. Then subsequently in early 2012, I think they came up with the so-called SLIC criteria. Now the latest criteria being published is an agreement between the American College of Rheumatology and the European. So they come in with the so-called entrance so-called criteria, which is ANA. So the person must have evidence of ANA positivity, which is 1/80 based on immunofluorescence. Only then you can apply this criteria. So the criteria must actually goes in, and then there will be a scoring system. So what will be the scoring system like? So this is the one. So they actually divided the so-called the organs into domain. Okay, they have the clinical domain, which is a constitutional symptoms such as fever of unknown cause, hematology, either you have leukopenia, thrombocytopenia, autoimmune hemolysis, neuropsychiatric, mucocutaneous. Then you have the serositis, musculoskeletal, and renal. This will be your so-called clinical domain. And then you have the immunological domain, which is a complement, SLE specific antibody, and the antiphospholipid antibody. So you need to add up all these things. If let's say you can get anything above 10 with the ANA positivity, so the patient is actually can be clearly classified into SLE. So SLE, like I mentioned just now, is a multi-systemic. So when we treat patients, we actually look into which organ domain is involved. So malar rash, which is very common, it involves the so-called the cheek and so-called excluding the nasolabial fold. Why? Because that is the area which is protected by the direct sun exposure. Okay, they are tend to be photosensitive and they heal without scarring. So this will be the typical malar rash among our Asian or this is Malay population. But then you have a more severe rash, which is a discoid rash. This unfortunately heal with scarring, which can be very mentally debilitating because patients really feel very depressed with that kind of scars on them. Yeah. The difference between malar and discoid is at the depth of the inflammation. The discoid rash involve more deeper dermis structure. So that's why when they heal with scar. So, and either is hypo or hyperpigmentation depends on your background skin. Okay, so for example, if you are when you are fair skin, then you heal with hyperpigmentation. When you are dark skin like Indians or blacks, they will tend to develop hypopigmentation. Mucous membrane, as mentioned, oral ulcer. Remember, most of the oral ulcers are painless. If you don't ask the patient to open their mouth, you will miss the oral ulcer. Oral ulcer will become painful only if there's a secondary inflammation or secondary infection. Alopecia is non-scarring most of the time. This is a good news because if it's non-scarring, if your SLE is under control, then the scar, the so-called alopecia will actually resolve. But if let's say the scarring alopecia will happen is due to the structural damage due to the discoid lupus, this will be the unfortunate lot because the scar will actually cause the hair will never grow again. Yeah. Cutaneous vasculitis, as shown just now in the cases, so it's because of the inflammation of the small vessel underneath the skin. So it does not blanch with pressure. And in worst scenario, it can lead to non-healing skin ulcer or even gangrene or even amputation due to the ischemia. So when you have vasculitis, usually the component is considered as moderate to severe. When you have skin vasculitis, we always try to look hard for evidence of large vessel or internal vessel vasculitis, because if it does happen, it needs to be actually managed more aggressively with stronger medication.
I see.
Arthritis, well, as compared to rheumatoid arthritis, arthritis in SLE are normally inflammatory in nature, but they may be RA-like pattern, but the good thing is that most of the time is non-erosive. This is the thing that we will normally miss if you rely on just slowly imaging without examining the patient, because the x-rays most of the time will be unremarkable, because remember, it is non-erosive. If you were to have a bedside ultrasound and you can do an MSK ultrasound, just like some of us, the rheumatologists, we can actually detect evidence of the kind of a synovitis or so-called tenosynovitis, but not X-ray. But of course, if you can get MRI, definitely you can get the inflammatory changes. But again, MRI is not easily accessible. Okay, serositis is a component that is related to so-called all the lining inflammation. The lining, the so-called peritoneal and the pleural, as well as the pericardial lining. So what happens is that if the serositis happens, so that will cause inflammation of the lining and cause fluid accumulation. So thus it's common to get pleural effusion, pericardial effusion, as well as ascites. And most of the time, one of the hallmark feature of serositis is that they tend to have high inflammatory marker such as CRP. whereby the other component may not have elevated CRP. So they can lead to symptoms of breathlessness, chest pain, palpitation, abdominal distension. In certain cases, it may lead to pericardial tamponade. It's a cardiac emergency. We had one patient who needed a cardio to put in a so-called the drainage. Yeah. And we may need to actually drain the so-called the pleural effusion because it so-called it jeopardizes with the respiratory function. It can be potentially life-threatening. It can mean that's another thing is that it's a diagnostic challenge, especially if the patient has no background of diagnosis of SLE. So if you have come with this, most of us will think of infection, isn't it? Then after that, we'll think of heart failure. Then we'll do this, do that, do left, right, everything. You know, the only thing that the patient will respond is high dose steroid. So steroid is the one that will actually makes the patient feel better. Hematology, it can be due to anemia, it can lead to leukopenia, it can lead to thrombocytopenia, and it can lead to autoimmune hemolytic anemia. So most of the time, what are the tests that is helpful apart from peripheral blood film is your direct Coombs test. Kidney is a major component that we really hate because once you have SLE kidney, it will involve higher morbidity and mortality. Okay, early telltale sign will be frothy urine and leg swelling without any reason. Kidney biopsy is important because it needs to confirm the diagnosis and staging. Because for those people who have a bit of understanding on lupus nephritis, you don't know very well that it comes in a different so-called class, from class 1 to class 6.
Tom yum, cá chii tom yum.
Sorry. Okay, go on.
Okay. I heard Tom Yum.
Yeah.
It's one of the main cause of end-stage renal disease. Yeah. So neurology, as mentioned just now, in the form of a case, the case scenario just now is a more severe form of SLE, and it is one of the components which can actually lead to delay in diagnosis because the presentation varies. Okay, it can come with seizure as the first presentation. It can come with acute confusion as the first presentation. Patient can become psychotic, okay, or even that kind of a sudden weakness or loss of sensation or loss of bowel or bladder control. So will lead to all these variables, and you can have many possible differential diagnoses in your mind during the first encounter. Okay, and then again, lupus headache. When everything is ruled out and is diagnosis of lupus, then for all you know, the headache is due to lupus. Yeah. Okay, principle of management is actually to identify which organ are involved and its severity. And the principle is to do good because we want to control the disease activity. We want to prevent damages from the disease. We want to prevent further flares because further flare will lead to further damages. And the damages, mind you, these are irreversible. Do no harm, minimize damages from the medication side effect. Unfortunately, all our medications involved in lupus treatment has its potential side effect. So if you do not treat the SLE, okay, for example, these two approach, if you follow the kind of old grandfather, grandmother approach, flare only you treat, you don't flare, you don't treat. So what happened, you notice that as time goes by, the blue line, okay, you notice that the clinical flare up and down, up and down, up and down over the years. Okay, it will lead to more and more damages along the years. Okay, and once the damages reach to a higher stage, it will lead to actually reduction in your long-term so-called lifespan, increase in morbidity and mortality. So that is why, just like other rheumatic diseases, there is a treat to target strategy for SLE as well. Meaning to say that when we treat, we need to reach the target. Okay, why? Because if we treat to target, we can actually reduce the frequency of flare and disease activity, thus reduce the so-called accumulation of the damage. Okay, thus prolonging the survival as well as so-called improving the long-term outcome. Okay, so don't be too shocked with this. This is just for you all to understand how we actually look into what drugs to use, treatment strategy, and targets of therapy. So as you can see, it can be divided into mild, moderate, and severe state. So different level of disease will require different form of medication. For example, in the mild stage, if let's say the patient involves skin or even a bit of joint, so the first line is always hydroxychloroquine. We love hydroxychloroquine. It's our wonder drugs. And then plus minus glucocorticoid. So when it's a bit refractory, then on top of hydroxychloroquine, you add on the so-called the anti-rheumatic drugs such as methotrexate or azathioprine. So when it's a more severe, you need more drugs. For example, hydroxychloroquine, steroid, all these things, and you may need to use more potent calcineurin inhibitor or even CellCept or mycophenolate mofetil. Okay, in a severe form, you definitely need more cytotoxic agents such as cyclophosphamide, rituximab, anifrolumab, belimumab. So that is why we always emphasize that when you diagnose SLE, you should actually hit hard and hit fast, treat fast in order to minimize the so-called the chances of the patient condition to progress from mild stage to severe stage. Because if you drag them for too long, you allow the disease to progress from mild to moderate to severe, you end up with all the so-called agents that you need to use on the patient. And not only is not cost effective, it actually create more morbidity, and not to mention about the medication side effect. Okay, so now again, my experience with patients when we talk about therapeutic and monitoring. So when we talk to the patients, and then sometimes all these third aunt and sixth grandma that comes together. So when we talk about drugs to use, so they will tell me that, hey, this SLE is like a death sentence because there's no cure. Yeah, it's very pessimistic, isn't it? So I will tell them that same goes for your high blood pressure, diabetes, high cholesterol, and heart disease, right? So you won't be telling Dr. Betty that because there's no cure, you don't want to treat, right? Yeah, yeah.
Our treatment less side effects.
Nah. Your treatment will damage your organ and it will not cure
don't they?
Yeah. Same thing also. The uncontrolled disease will also damage your organ, just like your diabetes, high blood pressure, and cholesterol, and even paracetamol can harm your liver. That time, my temper is already a bit up already. Yeah, and then the drugs are not natural. This is always what I get. And I'll tell them that, okay, if you want to know where this hydroxychloroquine comes from, it comes from this tree, the bark of the tree. It's grown in the South America. So if you want to take the natural one, you go and grow the tree and then eat the tree bark. So hydroxychloroquine is actually derived from this tree, just like your alfalfa. So this alfalfa is very common, isn't it? I can see this brand and people like to buy this. So management of organ dormant, so we'll touch a bit we don't go into detail. So for the cutaneous part, we will talk about, from topical to systemic to cytotoxic. You can see that the mild one, topical will do. UV avoidance, sunblock, and then topical steroid. But when you notice that it's getting more severe, you need more systemic agent, such as oral therapy, as well as even cytotoxic agent. Yeah. So cytotoxic, what are the ones? For example, azathioprine, methotrexate, mycophenolate, or thalidomide. Biologics, if you can afford or the patient has the access, belimumab, anifrolumab, or even rituximab as a off-label. Okay, we do have experience with patient responded very well to this agent with that kind of a severe skin problem. Musculoskeletal, so arthritis, again, steroid therapy may be needed at higher dose, 0.3 to 0.5 milligram, but you may need to add on with those who have poor response after the steroid and hydroxychloroquine, which is the commonest one, methotrexate. Leflunomide will be the alternative. Cytotoxic agent usually is not used in arthritis, but in a severe myositis not responding to high-dose steroid and methotrexate, yes, IV cyclophosphamide can be used. The other option will be mycophenolate mofetil. Azathioprine, honestly, is not really that helpful, but it's used as a second line. Hematology involvement, if you have severe thrombocytopenia, anemia, leukopenia, you need much higher dose of steroids as well as steroid-sparing agent. You need azathioprine, you may need cyclophosphamide, you may need mycophenolate, again, rituximab as a so-called off-label. Neuropsychiatric lupus, well, you can have all these possible features. It can come in the form of cerebral vasculitis, meningitis, encephalitis, optic neuritis, transverse myelitis, but all these itis are what you need is high-dose steroid. But before that, you need to rule out CNS infection. That's why you need your neurologist to come in to do a lumbar puncture to make sure that everything is a CNS infection is ruled out. So they need very high dose methylprednisolone pulse, and usually you pair together with cytotoxic agents such as cyclophosphamide. Yeah, maintenance is later on with mycophenolate and azathioprine. Okay, this is the one that we don't normally enjoy because these are the patients that will end up with long-term morbidity and mortality. So again, like mentioned just now, you need renal biopsy because it's established the early lupus nephritis diagnosis. Okay, you need to determine the severity and extent as well. So, but for the detail, I think we need not to know because this one will be handled by usually our nephrologist. Okay, another drug that we like to use, steroids. Okay, rheumatologists like steroid, like it or not, it's a wonder drug. But I know a lot of people hate steroid. Okay, so steroid, glucocorticoid is a good drug, but if it's being so-called wrongly used, all the good drugs can become poison. So it's a mainstay agent in SLE, irrespective of organ involvement. Okay, but how much you use, how potent it is used, it depends on your disease severity and organ involvement. Okay, so then when we talk about steroid, they will tell me that steroid is harmful. I don't want steroid because someone told me that steroid will damage my organs, causing diabetes. Well, I will tell them that you won't get DM within weeks or months, but your DM will kill you you will not kill you in days, but your severe disease will kill you in days. Okay, so it's a mainstay agent like I mentioned. So it depends on the intensity and potency. But again, we totally admit that the glucocorticoid dilemma is that while we want to actually keep it minimal, we also want to make sure the disease is well controlled. Why? Because if you actually stop glucocorticoid or steroid immediately, it may cause disease flaring. It may cause adrenal insufficiency. Then the endocrinologists will be very busy. But if you continue with a high dose steroid just to make the disease control well and to make you sleep better, then you end up with patients having a lot of long-term steroid toxicity. And honestly, you feel sad when you look at them with that kind of steroid toxicity side effect. So glucocorticoid therapy initiation is normally done in the first 4 to 6 weeks. Yeah, so we will try to reduce the dose accordingly. How much to reduce depends on individual response. Usually at a high dose, we tend to reduce at a faster rate during initial phase. Then subsequently, we'll cut down the dose at a slower rate. As you notice, for the subsequent dose below 10 milligram, there will be 1 milligram reduction. Okay, why? Because we do have the kind of 1 milligram steroid preparation available. It's not common. It's only available in certain hospitals. Yeah. The aim is to taper off, or honestly speaking, if let's say you can have the best scenario is the patient can totally steroid off. But if you can keep the patient at a minimum dose of around 2.5 to 5 milligram as a long-term maintenance and the disease is quiet, then everyone should be happy because studies have shown that anything below 5 milligram is a long-term maintenance. The risk and benefit is actually comparable. Okay, so what is high dose, what is low dose, what is moderate dose? So this is based on the EULAR grading, yeah, the European rheumatology grading. So low dose to them is anything less than 7.5, but I tend to be a bit stringy on that because I tend to try to aim 5 milligram, but sometimes it's very difficult. Medium dose is anything between 7.5 to 30, and high dose is from 30 to 100. You notice that, you see, the indications is based on what organ is involved. For those organ involvement that requires lower dose are generally milder. The one that involve a major organ are generally more severe. In terms of
100 milligram.
oh yes. Because remember we have pulse methylprednisolone, which comes in 1 gram a day. Yeah, so then after that you keep at even, but yes, I agree that in our setting we don't go beyond there, we don't go beyond 60 to 80 milligram a day, but in the West they do use up to that high dose, probably because of the body size as well. Okay, potency of steroid is also important. When you want to convert the doses of steroid, you must know what ratio, hydrocortisone to prednisolone to triamcinolone to methylprednisolone. So you need to know how to convert. Yeah, for example, IV hydrocortisone of 50 milligram TDS is equivalent to oral prednisolone around 30 milligram a day. So this is the thing that you need to actually know in order to adjust the dose. Sometimes when the patient need to change to oral to IV because NBM and so on and so forth. Okay, my favorite drug, anti-malaria, which is hydroxychloroquine, chloroquine. They are actually quinine derivative from these three grown in South America. So it's a mainstay treatment for SLE. Okay, so it comes in the form of chloroquine. Less toxic one will be hydroxychloroquine. Quinacrine, unfortunately, is not available in our area, but quinacrine, if let's say is combined with hydroxychloroquine, it really makes wonder on the skin improvement. It is an immune modulator. They are not immunosuppressive. That's why I'm not bothered to stop hydroxychloroquine when the patient has any infection or even COVID. Yeah, it has a lot of impressive benefit. So all SLE patients should be on HCQ unless there is an absolute contraindication. The dosage that we as a rheumatologist use to practice is anything below 6.5 milligram per kilo per day. So what are the benefits of hydroxychloroquine? It has been proven to prevent flare, increase survival, improve the kidney remission, reduce the renal damage, protection of renal failure. It improves the skin, musculoskeletal, and it also has anti-thrombotic effect. And it also has ability to reduce diabetes risk and cholesterol reduction. And for those people, yes. So it's a it's a wonder drug actually. Even though people
How
feel.
do you come to all this conclusion from a malaria medication, that it can
no,
treat SLE?
All this data has been actually proven based on the so-called all the years, the kind of studies, so-called the multi-center cohort studies.
Yeah, I believe that, but
Yeah.
how did, like, was it coincidental?
Oh, okay. How did
yes.
that is found? Oh, yes. Okay. So what happened was that based on my reading was that when the whites actually came to the South America and American region that time when then they met with the local Aborigines. So they noticed that whenever these so-called the people there, the local people there developed a kind of a long-standing fever, and then and so on. Then because of a malaria, then after that, then they actually improve with the so-called the consumption
The
of
bark.
the bark. Yes, correct. Yes. Then after that, they realized that, oh, okay, so this medication can treat the kind of fever disease. Okay, so it's only later on it's known to actually treat a condition called malaria. Same goes to lupus, because remember one of the presentation of lupus was unexplained prolonged fever.
Yes.
Yeah, so actually people just use it on these patients, and they realize that they improve after actually being exposed to being given this medication. So
Bark,
from
you
there,
mean the bark.
yes, correct. From the substance. Then only then when all this progress, and then they derive all these the ingredients
Molecular,
from
yeah.
Yes, correct. So it's all of like a coincident thingy. Yes, I agree with you. Yeah. Okay, so remember for patients who have for mother who has SLE, particularly if they have anti-Ro and anti-La positive, they tend to have a chances of delivering baby with congenital heart block. Okay, then by giving hydroxychloroquine throughout the pregnancy, it actually does improve or prevent the chances of congenital heart block occurrence on the baby.
Oh, interesting. Yeah. Okay.
So, but again, this is not a wonder drug. So HCQ toxicities do happen. It can happen on the skin. It can happen on the eyes. So what happened on the skin is that it can cause that kind of bluish skin discoloration. But this commonly happen among Caucasian. Okay, but for the Asian, it tends to happen in a way they have a generalized tanning of the skin. So they tend to become darker and darker as time goes by. Usually the accumulative dosage beyond 2 years of hydroxychloroquine may start to see the kind of a skin pigmentation. Some patients will be longer, some patients will be shorter period. It depends on their metabolism as well. But the other one that we are more concerned is retinal toxicity, because progressive accumulation of the hydroxychloroquine or the chloroquine into the retina will lead to the kind of maculopathy. So what are the risk factors? Total daily doses and duration of use, advanced age, those with renal impairment, or even those with existing retina or macular disease. So even though the rheumatologists, we rheumatologists feel that we can use up to 6.5 milligram per kilo per day, but the American Association of Ophthalmology came out with a recommendation not to use more than 5 milligram per kilo per day. So I also tend to stick to that nowadays.
Do
Okay.
you send all your patients for eye checkup then?
Okay, so that is the thing. If you look at the studies from the AAO, the incidence of toxicity before 5 years is almost negligible. It's actually less than 1%. So I don't routinely send my patient for baseline ophthalmology checkup. Yeah. But I will tell them that if you were to develop a bit of funny symptoms or eye symptoms, particularly blurring of vision, or if you notice that how come your vision, especially the color is not as sharp as before, then please let us know. Then we'll send you for the OCT, ocular CT, to look at the retina layer. Otherwise, the current guideline is that yearly ophthalmology checkup is needed if the person is actually taking hydroxychloroquine continuously beyond 5 years and beyond. Then you need to have a yearly so-called assessment. Yeah. So if you can see, the risk of toxicity up to 5 years is under 1%, but up to 10 years is under 2%. But then if let's say 20 years is almost 20%. So what will be another way that I deal with this is that after a certain period of time, we will try to actually taper down the so-called the dosage of hydroxychloroquine. Yeah. Normally, if the disease become quiet 1 to 2 years later, I'll tend to cut down the dose in order to reduce the risk of subsequent so-called toxicity occurrence. But again, I must admit that there are times whereby even the patient just need this high dose. We just can't help it. So we will need to just monitor them closely.
Does the disease burn out by itself?
Good question. Okay. The old tale is that the disease will tend to burn out when actually they burn your kidney.
Oh.
So the old understanding is that if the person is already developed end-stage renal failure and started dialysis, oh, so same goes to your lupus is quiet. No, actually it's not the case. When will the disease be quiet? If let's say the disease is kept in a very so-called remission state for years, and when the person, particularly for female, when they reach menopause, somehow after menopausal period, they tend to become quiet and we are able to taper down or even taper off the medication. But the general principle is that the person must have the so-called disease in remission, in sustained remission for years. Yeah. Okay, so lupus and pregnancy is a very important thing to discuss because, as mentioned, many of them are childbearing age women. Yeah, 20 to 40 years of women as a common age of onset. So we have to talk to them and the spouse. Remember the spouse. Okay, the best time and best condition for pregnancy, and have to map up the pregnancy plan and what are the medications to use and what are the potential side effects and what will be the monitoring like. Okay. So risk to the mother, of course, they may actually increase the flare of lupus. It can develop complication of pregnancy, such as diabetes, infection, pregnancy-induced high blood pressure, preeclampsia, even thrombosis, particularly on those patients who have existing anti-phospholipid antibody. Risk to the fetus, miscarriages, premature birth, neonatal lupus, congenital heart block, as well as the concern of some medications that can cause birth defect. Yeah. So pre-pregnancy consult is very important, reliable contraception, assess the risk factor for pregnancy, and please, I always tell my patient, aim for stable and well-controlled disease for at least 6 months prior to conception. Yeah. So summary. Okay, so SLE, autoimmune disease, multifaceted features because it comes from your gene and it needs some triggers. So untreated SLE will lead to increase in morbidity and mortality. The treatment aim is to prevent flare, remission, if not low disease activity, and prevention of damages. Anti-malaria, particularly hydroxychloroquine, is the utmost important medication. And please remember, no two SLE patients are the same. You cannot copy the one regimen to another patient. And in real life or in ideal situation, it should involve multidisciplinary team. and holistic approach in order to ensure successful treatment. Okay, I think that's about it, Betty. I hope I
Wow,
don't
thank you for
everyone.
very comprehensive talk.
Mm.
It's very interesting. But I want to ask, so it's not completely contraindicated for patients to get pregnant.
Oh, no. I have patients who are able to actually get pregnant and deliver their child, but I must admit that there will be some challenges here and there. Yeah, there will be some challenges here and there. So like, for example, one patient towards the third trimester developed reduced amniotic fluid and need to actually carry forward the delivery timing. One patient developed some telltale sign of lupus nephritis with new onset of proteinuria, in which I have to pause the patient with steroid. Luckily, she worked. Actually, we didn't actually allow the lupus nephritis to progress. And then she managed to deliver the baby healthily. Another one, she actually developed flare-up 6 weeks after postpartum. So yeah, so there are challenges here and there. Then in between, not to mention those people who have recurrent miscarriages, and one Chinese lady, the China national, I'm still managing her, was referred to me in 20 weeks pregnant, prolonged fever with thrombocytopenia, only turned out to know that she has lupus onset in pregnancy. And she developed very bad lupus until she has to be intubated, and we lost the baby. Yeah, we lost the baby, unfortunately. But we kept her alive lah. Yeah, that's the important thing lah.
That's the most important thing.
Yeah. So
Okay.
yeah, so yeah, they can get pregnant. So there are medications which are compatible to pregnancy. So do not simply just stop the medication. Do not simply just off the medication. For example, I have a patient. No, it's actually my friend from Alostar last time. He said that one mother SLE was actually off azathioprine, and she came in with a full-blown pregnancy, and she actually ended up intubated.
SLE, you mean?
Yes.
Oh,
because once she's confirmed pregnant, the doctor actually off the azathioprine, which is a wrong thing to do. Yeah. So
okay, we take some questions.
Yes, please.
Okay, we have some questions. So Dr. Susie from Docquity asked, what are the different type of small molecule drugs that can be used to treat SLE? Small molecule drugs.
Small molecule drugs. I'm not sure what does she mean by small molecule drugs though, because when we talk about medication, okay, apart from we talk about corticosteroid as a mainstay, anti-malaria as a mainstay, then the others will be the so-called immunosuppressive. Immunosuppressive can range from methotrexate, azathioprine, cyclosporine, mycophenolate mofetil, thalidomide.
But there is no group that is small molecule drug.
Small molecule, no, unless you are talking about biologic. Biologic, they are not small molecule. So small molecule, my understanding is those JAK inhibitor, which is used in rheumatoid arthritis, but not in SLE. Yeah, so far, no.
Okay,
so far, no.
We move on. David Neto asked whether you can show the slide that shows all the autoimmune diseases or not.
Oh, the one that for the initial one, huh?
Yeah.
Okay, can.
Okay, while you're looking, I read out another question.
Yes,
Dr.
please.
Thompson from Docquity asked, I hope you can share with us your view on biologic treatment in treating SLE. What is and do you have any experience in all these drugs that I cannot? Okay, you can read on the chat also.
Rituximab. Rituximab. Yes, rituximab. Yeah, rituximab is
a few, especially patients who have hypersensitivity reaction towards prednisolone.
Wow, hypersensitivity towards prednisolone. I wonder what sort of sensitivity. Okay, biologic agents. Okay, they are useful in those moderate to severe form of lupus. Okay, because few things here. Biologic agents that have been used in licensed to be used in lupus so far, you have the so-called rituximab, the good old rituximab, the anti-B cell. The principle is because you know that the B cells are the one that actually produces antibody and autoantibody. So you actually block the the B cell. Okay, so-called it's called B cell depleter. Then you have belimumab, okay, or Benlysta, which acts on the molecule level of this BAFF. So this one, you need to understand about the molecular level. Then you have a new one, interferon, which is called anifrolumab. Okay, so far, okay, anifrolumab has good features for skin, has good features for MSK, has good features for fatigue improvement, and they are actually good in steroid sparing. Okay, it's a monthly infusion. Belimumab, also fatigue, skin, as well as so-called a bit of hematology, and recent data has shown that it seems to work also for patients with lupus nephritis. It's also a monthly infusion. Rituximab is a 6-monthly infusion. So basically, in more severe form of so-called SLE, regardless which component, rituximab can be used. Accessibility is issue, but at the same time, you need to know when to use and when not to use, because these are more potent immunosuppressive biologics. They will bring you some issues on infection. Yeah, because remember, these are all targeted on your immune marker, immune so-called molecule. So if you use too freely, or you put patients on biologics, the risk of infection is always there.
I
I'm
see.
not sure about hypersensitivity towards prednisolone. What does it mean? Does it mean the patient has a lot of allergy? I don't think patient will allergic to prednisolone. Is there any cases of that?
Well, okay, I don't know about prednisolone, but I had a case who had chronic asthma who is allergic to IV hydrocortisone, and I didn't believe him. Nobody believed him, and every time he will get an anaphylactic shock. So another doctor asked, Anderson Ma asked, what is there any use for immunoglobulin in SLE?
Oh, yeah. IVIG. I didn't touch that part. Okay, IVIG can be used in an acute setting whereby you need to actually get all the so-called immune cytokines while the XLE is very active to be wiped out. So you can give IVIG infusion in those very severe, active, life-threatening lupus. Yes, we do give that. Another way is plasmapheresis. We actually do the kind of plasmapheresis that will involve our nephrologists. So wipe up all the so-called autoantibodies from attacking the organ temporarily. This is life-saving, temporary life-saving to buy time. Yes, we do practice that. Yes, I agree. But it's very costly. It's a very costly treatment.
Okay, somebody mentioned that she's very happy that you had this sharing, and because her cousin just passed away 3 months ago from SLE. So
I'm very
believe us,
sorry.
SLE is truly if not well treated, can be a very life-threatening illness. Yeah.
I'm very
So
sorry.
Dr. Zainal from Doquity asked, how do you choose which case to taper off prednisolone completely and which case to maintain at low dose?
Good question. When you see the patient long enough, you know how their disease pattern work. So you know how their response to adding this medication, minus the medication. So that comes with a bit of knowing your patient better. So in private practice, we do have that kind of a privilege because you get to see your patient back again and again. And then as time goes by, you know, okay, we can try to do this because last time but I don't have answer for you, but my general statement is that you need to actually assess the patient objectively to make sure that the patient is in remission, and then in remission long enough before you decide to taper. Number two, you also need to look at the patient baseline. What are the so-called, how severe is the SLE to start off with? If it's a mild, like for example, skin or MSK, you may be able to taper down the steroid faster. But if it's kidney, if it's heart, or if it's lung, or if it's a brain, no, definitely you need to actually drag a bit longer. So, but every patient, the individual response is different. Yeah.
Okay. Then he went on to ask, how long in remission before you decide to taper off dose of the initial prednisolone or hydroxychloroquine hydroxychloroquine.
Okay, so if let's say the idea is to aim to bring down the so-called the prednisolone dose to below 7.5 milligram or equivalent within the period of 3 to 6 months if possible. But I can tell you that most of the time, often, especially those who are involving major organ, it's a bit hard to do that. So 3 to 6 months to reach, actually it's 3 months lah, but we are not that aggressive in the way that, because we really know that it doesn't work that way. So 3 months ideally to aim to bring down to 7.5 milligram. Okay, hydroxychloroquine, no, actually my idea of tapering down hydroxychloroquine is when they are actually in a disease, the disease state is quiet for at least 2 years and beyond. I will start to actually cut down the hydroxychloroquine dose from daily to alternate day or something like that. Because as time goes by, the dosage of hydroxychloroquine accumulation is long enough and you get accumulated in your body. So even by tapering down the dose, you will not lose its efficacy. Yeah.
Okay, can I ask you what parameters do you use? Do you use clinical judgment, for example, the skin lesion? Do you use ESR, CRP?
Yeah,
All of the above.
we use a combination of everything, but in a so-called a very objective way, there's a score called SLEDAI score, SLEDAI, the disease activity score index. So SLE disease activity index. But the problem is that in real life, we normally don't follow strictly on all these SLEDAI score. It's more towards for study purposes. So like what you said, clinically, we look at which organ is involved, then we actually assess clinically each component, then the parameter, ESR, C3, C4, urine, but you need to know what's their baseline. If someone with a normal ESR, CRP, there's no point of comparing. If someone with a normal C3, C4 to start with, there's no point of comparing. So you need to know their baseline.
Okay, Dr. Chen CK Kai she said she came across a patient with only presentation of mala rash. She's a middle-aged female, did not complain of joint pain.
Yeah.
Further history, no excessive hair loss, no multiple visits to hospital, no fever. FBC was normal, renal function. Do we need to do an ANA or double-stranded DNA prior to referral to a rheumatologist?
Okay, if you are talking about just a cutaneous, I mean mala rash, and you are not sure whether this is cutaneous lupus or not, just go and see. You can refer to a dermatologist first. You can actually, not necessarily rheumatologist, because dermatologists they do actually manage cutaneous lupus very well as well, most of them lah. But if you want to do an ANA, yes, why not? You can do an ANA as a screening test. If an ANA is positive, it increases your so-called suspicion on this possibility that the mala rash can be underlying lupus-like problem. But even if it's negative, doesn't mean that it's not though. So mala rash has a so-called the kind of a feature that can mimic certain other kind of so-called skin conditions such as rosacea. Yeah. So the dermatologist will actually know how to differentiate between the two.
Okay, Dr. Ong Han Yi asks, is there an absolute contraindication for hydroxychloroquine?
Absolute, if they are proven to be allergic to it, that's for sure. That's why for sure they are contraindicated. Other than that, no, the others are mainly relative contraindication. Relative contraindication are those people who has severe renal impairment, because they tend to develop hydroxychloroquine toxicity faster. For existing eye problem, for those people who has so-called
long QT.
Something like that, yes, that kind of rhythm problem, because quinine based or hydroxychloroquine, they do affect the so-called the conduction. Yeah, so that one need to be a bit watchful, but it's not an absolute contraindication.
Okay, there is a question from Dr. Ben Manjun. If SLE patient comes with infection and if he or she is on the methotrexate or azathioprine or prednisolone, do we off this medication when he's having ongoing infection?
Okay, it depends on how bad is the infection. If it's a systemic infection that warrants antibiotic, then or warrants anti-infective, probably you need to stop the methotrexate azathioprine, the immunosuppressive. You need not to stop the hydroxychloroquine. You need not to stop the steroid. Okay, you need not to. But if it's a more severe sepsis that requires IV antibiotics, then that will require hospital setting. Then we will adjust the dose accordingly. For example, the steroid we may change to IV instead of oral or something like that. Yes, immunosuppression is okay to stop temporarily just for that few days, just to wait until the infection settle. But you need not to stop hydroxychloroquine. You need not to stop prednisolone. Yeah.
Okay, Ashwin, you asked, is there any benefit of, or what is your take on vitamin D as an immunomodulator?
Okay, good question. Studies have shown that vitamin D deficiency tend to happen among lupus patients, and those lupus patients who have vitamin D deficiency, somehow their disease tend to be a bit unstable. They still cannot prove there's a direct relationship between the two, but they can smell the link. Okay, so yes, I do agree that if patient has vitamin D deficiency, you should actually correct the vitamin D. That in long run does improve your so-called the disease activity, because vitamin D is also a kind of immune modulator, but they are not supposed to be used as a sole treatment for SLE. So you still
Okay.
need to use the anchor drug.
Christine Saw asked, what's the incidence of transitional cell bladder cancer in SLE on cyclophosphamide?
I was hoping that I will avoid that because I really can't remember the data, but I can assure you that based on the local experience, the incidence is actually very low. And honestly speaking, nowadays, more and more of us try to move away from the high dose cyclophosphamide. If you were to know a bit of a cyclophosphamide regimen, there were the NIH regimen, which is a high dose cyclophosphamide for 6 months to 12 months. That one is the one that actually had a lot of issues with premature ovarian failure and risk of bladder toxicity causing bladder cancer in long run. But subsequently, when we talk about Euro lupus regimen, whereby it's a lower dose of so-called cyclophosphamide, the incidence is actually much lower. But I'm sorry, I don't have the data.
Okay, Dr. Sitapong asked what the criteria we use in nowadays for SLE. I think you have mentioned that.
Yeah.
And I was hoping that you can share the slide in PDF form for me to share with everybody.
Can.
Can, okay. Dr. CHEAH, okay, is there a treatment guideline that they can follow for pregnant SLE mothers?
I think KKM does have a guideline on that. Please go to the website and check. Otherwise, you can actually go to ACR and EULA. Just click EULA guidelines and then put their pregnancy, SLE and pregnancy. There is a so-called the EULA recommendation on so-called SLE in pregnancy. What are the do's and don'ts, the general principle? Yeah. But I think KKM also does have it. I can't remember honestly. Yeah.
Okay, Dr. Isa asked, okay, especially in the primary care, patients on SLE treatment, would you just generally start them on antibiotic if they have URTI?
No.
No, right? Because if it's viral, it's viral, right?
Viral is viral. Yeah.
Okay.
I mean, even though they are SLE, doesn't mean that everyone should get antibiotic.
Yes, I think we should still practice the general guidelines and not increase the risk of
Overuse of
resistance. Yeah.
antibiotics.
Okay. So this is actually the QR code. You also can actually
I also can scan.
yeah, you can use the MMA, and later you can also give me all your details to get 5 points as a speaker.
Oh wow.
Yes. So screen it with your MMA app and then you can get 1 point. So it's only for doctors and it's only for Malaysian doctors, yeah? And that was a extremely good talk. Very, very informative, very, very good flow also, and covered a lot for both the general public, the GPs and those trainees that are interested in doing rheumatology, and of course, a certain cardiology who's running the webinar. Okay, let me just end the, okay, I can't end this one. Let me stop the live stream. Okay, and then I will stop recording. Okay, thank you, everybody.